IPAP is the kind of art used for it, and it looks at making sure that Medicare expenditures hit growth rates. And it does that through some other boards and things that are happening, and one of them is the Institute of Medicine. In fact, I'm going to be going back the first week in October. We're having a national conference, and it's dealing with geographic disparities and why did we find that there are some states in Minnesota, Wisconsin, Oregon, Washington, even though our doctors were being reimbursed and our hospitals were being reimbursed, why were they so successful in improving outcomes? So it isn't always money that is what it takes to heal a patient. It's innovation, it's teamwork, and an example of one of the studies that early on had started moving forward in healthcare reform, and that's why there's more of them in here, is what I was referring to last night with United Hospital. United decided to apply for an innovation grant because they wanted to become a center of diabetes excellence at the hospital. In other words, reduce patient stay. If you do that, you reduce patient cost. You reduce the cost on the whole burden of the healthcare system. So they got together as a team, talking to patients, talking to nurses, talking to families. What do we need to do to improve the outcome so that when the patient leaves here healthier, more compliant, and more in control of their diabetes. And with that, they just received the award. They made all their goals. They improved patient care, and they saved money. And patient care was their first and foremost goal. They were never going to let the patient not be their top priority. But when you do that, when you put everybody in the room and you start talking together, amazing things can happen. And that's what IPAB is going to be working on with the Institutes of Medicine. Dartmouth has all kinds of studies they can point to, so maybe you'd like to speak to that.
So my comment was going to be about the geographic disparities. When I was at Dartmouth, I worked with the people, if you've heard of the Dartmouth Atlas, that have put that together. And it's really compelling. And Minnesota always is either lit up as a high-quality state or unlit as a high-cost state. And the formulas have not been fair in reimbursing that kind of effort. I think we do need to fix the payment rate. I think, though, we cannot keep emphasizing doing more volume. I liken that to a turn of the hamster wheel. In fact, that's how we talk to our doctors is the current payment system rewards how fast you can turn the wheel. And instead, really focus on the outcomes and what is the impact we've had on a population of people, whether it's an individual doctor's panel or the panel of a clinic or the Fairview Health System as a whole. And we're developing ways to be able to measure that and report it and monitor it and see kind of what kind of impact we can have. And in fact, we're investigating right now a new way of paying our doctors in our medical group to get away from how many clicks of a hamster wheel did you do last month, to focus on satisfaction, to focus on how did you meet a patient's need besides having to come to the office. Could you have handled this by a phone call or through a team-based care model with your nurse or a social worker or someone else participating on the team and such. And again, that's a reason why I'm so delighted to be with this brave organization that's taking these steps. The other thing I'll say that Minnesota has a somewhat of a blessed advantage in some of this work is that in Minnesota, I think the number is like 70% or so, up to 3/4 of doctors practice in larger clinic organizations, so like Mayo Clinic, the St. Joseph Mankato System, Fairview, Alina, Park Nicollet, St. Mary's Duluth, Avera down by Sioux Falls, and Merit Care up by Fargo. And that really provides an organizational strength to do quite a bit of this work that can't occur in a 1 or 2 or 3 doctor practice. And most of the country is still organized with doctors in 2 and 3 doctor practices. So you can imagine the weight pushing back against some of these proposals to be in a team. It's more difficult, although it puzzles me why, to be a team in an office of 3 people than it is in a Fairview with 450 doctors divided up into little teams. But there's an infrastructure and cost that's not always provided right now by our payment methodologies to allow you to do that kind of work.